Merci à tous mes amis français qui m'ont invité à ce congrès. Malheureusement, j'étudiais le français seulement à l'école et je ne peux plus faire une présentation en français. Today, I want to speak about a new possibility. A new possibility regarding the comorbidity of dual disorder, drug addiction, and mental ill. And I want to introduce you towards a specific psychopathology of heroin addicts. Why? Because we are convinced that it's impossible that a drug addiction is only related to craving and relapse. You know that all psychiatric patients have a specific psychopathology. There is a specific psychopathology for depressed patients, for psychotic patients, and so on. And no specific psychopathology for drug addicts. It's possible to make a diagnosis of drug addicts in men, in animals, in the same way, with the tolerance, dependence, and no good in social adjustment? No, probably there is something linked to the emotion, to the thought of our patients that is specifically linked to a psychopathology. Psychopathology linked to the progression of the illness. So many years ago, we tried to delineating a psychic structure of substance abuse. And we considered anxiety, mood, and impulse control, dysregulation, as a specific psychopathology, as a core of the psychopathology of drug addiction. We started to study this problem in our patients recruited in a psychiatric hospital in my university in Pise. And the question was, is depression linked to a dual diagnosis? When drug addicts, heroin addicts have a depressive state, there is the co-presence, always the co-presence of a dual diagnosis. And we found that in reality, depression is the most frequent psychopathology in heroin addicts at treatment entry. But the link with the dual diagnosis is very poor. There is no high correlation between depressive state and the presence of dual diagnosis. So, for example, for depression, what is the cause of this depression in drug addicts? Comorbidity, dual disorder, or a specific depression? And in this case, what kind of depression we are facing? So we started to use a checklist for psychopathological symptoms to try to identify dimensions, clusters of patients characterized by psychopathological symptoms at treatment enter. And using the SCL-90, we noted that in psychiatric patients we can have a 9-factor solution. And if we consider addicted patients, we have only a 5-factor solution. And this 5-factor solution, worthlessness and being trapped, the somatic symptoms, sensitivity, psychoticism, panic, anxiety, and violence, suicide, using this kind of structure is possible to classify our patients, all our patients. Why? Because we can consider the Z-test, the Z-score obtained by our patient, and we can, in other words, made a color for our patient. If Z-test, Z-score is higher in worthlessness and being trapped symptomatology, we can say that these patients are characterized by worthlessness and being trapped. So you can understand that we can divide the patients on the basis of different kind of symptoms, but also not considering the intensity, the severity of the symptoms. All blue patients are blue, low in blue or high in blue, but they are blue, different from yellow, red, and so on. This is a new classification, and we can introduce this kind of classification in our clinical practice, especially at the end of my presentation. I will show you some effects on treatment of our patient. So we started with the identification of this kind of factors, and we started to correlate some kind of variables linked to the addictive process. For example, you can see that the age is important in distinguishing this kind of patients, and especially worthlessness and being trapped is higher, is the characteristic of older patients. So, for example, somatic symptoms that are linked, in my idea, to the withdrawal syndrome, opioid withdrawal syndrome, is no linked to the age of the patients, but sensitivity, psychoticism, violence, suicide are more pronounced in patients. They are younger than patients characterized with worthlessness and being trapped. And this makes sense, especially if we consider that worthlessness and being trapped can improve if treatments are not good and relapsing in the illness. After this identification, this identification was made in patients arriving for the treatment with agonist opioid treatment. We considered patients entering therapeutic community. And we found a high correlation between the dimensions isolated in people entering opioid agonist and in patients entering therapeutic community. As you can see, there is the same structure. If we cluster patients in entering opioid treatment, or we cluster patients entering a therapeutic community, the kappa is very high, more than 60, 0.60. That means that the structure of a psychopathological symptom is very similar in patients entering residential treatment and the patients entering therapeutic agonist opioid treatment. If sensitivity, and we can also study in this way the differences we use in inputting patients in an outpatient clinic or in a therapeutic community. For example, you can see that patients characterized by panic anxiety generally enter therapeutic community, but patients with a high somatic symptomatology or somatic symptomatology, sensitivity and psychosis and violence and suicide, doctors prefer to maintain this kind of patients in an outpatient clinic. So we can understand also what we are doing in treating our patients. After that, we considered some variables linked to the progression of addiction. For example, the status in which patients are coming for treatment, intoxicated by heroin or not intoxicated, to study the correlation between the intoxication status and psychopathology. And you can see that the severity of symptoms are higher in patients not detoxified in all the dimensions studied, and especially in somatic symptom. And this is clear, is true, is right. But if you consider the quality, not the quantity, but the quality of psychopathology, you can see that, for example, worthlessness, being trapped is the same, violence, suicide is the same, and of course, somatic symptoms are more represented in non-detoxified patients. And look, it's very interesting that after detoxification, patients with sensitivity psychosis are more present in our group. So, in some cases, detoxify patients is a good perspective. In other cases, maybe not. Another variable we consider important in the specific psychopathology of drug addiction is the psychiatric comorbidity. In this case, we analyzed the presence of psychiatric problems in our patients to study the effect of psychiatric problems on the 5 psychopathological dimension. And also in this case, you can see that the intensity of these dimensions are more pronounced in patients with psychiatric problems, lifetime psychiatric problems. But the quality is very similar. It's very similar. You can see that the quality is not different. The significant, the chi-square is not significant. It means that patients with psychiatric comorbidity or with psychiatric problems documented in the history of the patient, they are in therapeutic community, so it is easy to do that. Patients with the psychiatric problem and without a psychiatric problem are not different in the quality of psychopathological symptom. So is very difficult to speak about only about comorbidity, because also in heroin addicts without psychiatric comorbidity, the structure, the quality of psychopathological symptoms are the same. The intensity, no, the severity is higher in psychiatric patients, but the quality, the color, at all levels of severity, the quality, the characteristics are very similar. And now I want to show you something that is not still published, because it's very difficult to publish this kind of a paper, because the idea of editors is that only comorbid psychiatric problem there is in drug addiction. So the most important journal tend to refuse this kind of idea. But we are continuing to test this hypothesis, and now we try to demonstrate that this kind of structure is not correlated to the kind of substance of abuse. Is similar in alcohol, heroin, and cocaine. And is similar. It's not the same, but is similar. And you can see that the only psychopathological strata that can differentiate alcoholics patients from heroin patients is sensitivity psychoticism. But we know that alcohol has more power in this kind of psychopathology. And for cocaine, the differences between heroin patients and cocaine patients is that somatic symptoms are more frequent in heroin patients. But this is true. Is a clinical observation. And it's really interesting that the other dimensions are not able to differentiate patients using heroin, using alcohol, using cocaine. In this case, we consider the primary substance of abuse. Of course, there is a limitation because we haven't patients using only one substance of abuse. But we can request the patients to say what they consider the principal substance of abuse. If we consider not only the primary substance of abuse, but also the secondary substance of abuse, alcohol and cocaine, you can see that there is no difference in the quality of psychopathological symptoms between heroin addicts without the use of alcohol and cocaine. It's a very limited sample, 85 on 2,000 patients. And if you consider the high number of heroin plus cocaine, but in this case, the significance is not present. So, heroin addicts with the use of alcohol or without the use of alcohol and cocaine have the same structure, psychopathological structure. This kind of patients are patients without any other substance of abuse. And you can see that also in this case, the quality of psychopathological symptoms are not significant different. But why we are in progress in this kind of idea? In Latin, cui prodest? Cui prodest? Because we are convinced that methadone and buprenorphine are not the same effect on this kind of psychopathology. And also in the psychopathology, in the dual diagnosis. But our idea is that methadone and buprenorphine are different, not only in the treatment of dual diagnosis patients, but also in patients without a dual diagnosis that present some characteristics of psychopathology. We started our studies with this report in 2000, methadone dose and retention during treatment of heroin addicts with and without ATHS 1 psychiatric comorbidity. This is an observation, 3 years observation, and you can see that the patients with the dual diagnosis stay in treatment without a significant difference with the patients without dual diagnosis if you are using a little bit dose of methadone higher than standard. I remind you that the standard dose of methadone is comprised between 60 and 120. A dream now, but in the past was the idea, the major idea to treat heroin addicts. If you are using an overstandard dose, 150 and 100 for non-complicated patients, you can have the same results. This was important in 2000 because psychiatric comorbidity was an exclusion criteria for methadone treatment in the United States, not in Europe. We found this kind of effect in Europe. De Glon was one of the first doctors to find the good effect of methadone on psychopathology in the Phoenix Foundation. And we repeated the evaluation, our evaluation after 10 years. And the results was better. After 3 years, no differences. After 10 years, yes, there is a difference, but in favor of the presence of a dual diagnosis. And this is very clear. Also in this case, over standard of methadone. And this is the last, well, not last, the latest, our research about, I hope not the last, our study regarding the outcome of bipolar 1 patient treated in an enhanced methadone maintenance treatment when they were not responding to the normal treatment. We recruited this kind of patients, resistant patients, in psychiatry, treated with mood stabilizer, and in drug addiction unit using methadone. And using mood stabilizer plus methadone over standard dose of methadone, we reach this kind of results that is without doubt in favor of bipolar 1 heroin addicts. Diagnosis and psychopathology if we consider the structure in 9 factors, there is a specific improvement of psychopathology under methadone and under buprenorphine. You can see that methadone generally also, if the psychopathology is higher, results are good, like with buprenorphine in a double-blind study or in an open. But if we consider the 5 cluster solution, you can see that, for example, violent suicide people have better results if treated with the buprenorphine, and sensitivity psychoticism patients have best results under methadone treatment. And during the therapeutic community, we have the same aspect. The psychopathology can influence also the results of treatment in a therapeutic community for 15 months. You can see that the patients characterized by violence and suicide have a poorer outcome that patients characterized by sensitivity and psychoticism. And this in heroin addicts, but also in alcoholics. You can see the differences between violence and suicide patients and worthlessness being trapped, and also between violence, suicide patients and panic, anxiety patients. So far, we can state high rate of psychiatric symptoms among heroin addicts cannot be overlooked or under-evaluated. It's not only a problem of comorbid patients. There is a psychopathology also for non-comorbid patients. Probably these symptoms can characterize patients independently from intoxication status, psychiatric severity, and concomitant substance use disorder. Probably this symptom can influence treatment outcome, not only methadone and buprenorphine, but also therapeutic community treatment. Probably therapeutic opioids are effective on these symptoms. Probably psychiatric conditions predict outcome in methadone or buprenorphine-treated patients. Probably treating heroin addiction with therapeutic opioid, we can treat psychiatric comorbidity. It's our job. I hope to present new data at the next Congress here in Biarritz. Thank you for your attention.